Hi everyone. Thank you for choosing to listen in again. February happens to be our anniversary month at Jindal Healthcare. So a quick throwback to years ago, the very first claim that we worked for Jindal Healthcare operations, the very first claim we coded, the very first phone call that we made was for a pain management provider group. And then cut short to 2025, we've probably worked for 250 to close to 300 odd pain management providers across several different states with clinics of varying different sizes. So I think I'll always be partial towards pain management as a clinical specialty. And it hurts me a little bit that pain management as a specialty is just more prone, more vulnerable to a messier prior auth process. And take this time to talk about three specific reasons why that is so and what we could possibly do about it. Number one, excessive and non-standard documentation requirement. Are there payers that can approve an SI joint injection, a hip joint injection, without asking for multiple provocative tests? There are. Are there payers that are sticklers for asking for multiple provocative tests to approve the same SI joint injection? There are. There are larger payers where within the same payer, for some services, you need to make them a phone call to get something approved. For some other services, for the same payer, you need to go to availability to get an approval. For some other services, once again, the same payer, you need to go to a different portal, RadMD, Olive, NIA, and for yet some other services within the same payer, you'll probably need to send them a fax and wait. Is this excessive? Sure is. Is this preventable? Most likely it is, but it is 1,000% burdensome and excruciating for providers and practices. So that's one. Number two, the tiptoeing and the tightrope balance between what is clinically necessary for the patient versus what is payable by the insurance. A pain management provider, a physician who went to medical school for years, who's been treating a chronic pain patient for another set of years, decides that the patient needs an RFA done, and then a computer program at the insurance company or a static rule book at the insurance company, or sometimes even a human being at the insurance company, based on maybe 3 progress notes, is deciding that the patient doesn't require that RFA. I mean, it's obviously bad for the patient. It also leaves the providers with no good choices. They can either not do it, knowing very well that that is exactly what the patient needs, or they do it and ask the patient to pay for it, which is not easy, and most practices don't want to be doing this, or they keep going into this endless cycle of having to appeal the denial and ask for a peer review or send out a claim and then appeal the denial of the claim. Once again, not great. Don't even get me started on the urine drug screen confirmations. These are being done to maintain the efficacy of the treatment, to make sure that there is no clinical abuse. There are payers that mandate only a certain number of drug screens can be paid every year. Makes really no clinical or compliance sense, but that's that. Number three, longer processing times and higher than usual denial rates. We've had cases where we submitted an auth request, waited for say 4 days, gave them a phone call, the insurance said, hey, we don't need anything, it's in process, it's probably going to take 2 to 3 weeks. Our teams have been insistent and persistent that they want to talk to a nurse reviewer on the phone. So they stay on hold, waiting for the nurse reviewer for 40 minutes. They then talk to the nurse reviewer for say another 15-20 minutes, and they're able to get an approval right then and there. The problem though is, how many cases can we do this for? And should this even be the process to handle this. As a practice, as a healthcare provider, I can only choose to do this on a certain number of high priority cases. But insurance can literally deny any approval request that they get. And the onus of proving medical necessity is on the provider slash patient and not on the payer to prove why this is not medical necessity. This literally makes my brain hurts. I don't know if you all can see this. It's a sticker that says my brain hurts. And I don't mean to sound any doomsday alarm here. The few things that we've tried to do over the course of years, things that have worked better than the others, things that have helped us build a sustainable process to minimize our damage. There's a long form content coming later this week. Talk about some of the solutions that we've put in extensively, because it's probably going to be too much for a small video like this. So please keep an eye out for this, and I'll see you all in the next one. Bye.